Okay, thank you, Philippe and Nozaire, and I want to indicate that Alexandra Rodenko could not be here, but this is entirely her project. She conceived of the project, she rounded up the cases, she did the studies, and worked with the surgeons to get the follow-up. In this talk, she is looking at the utilization of time-resolved MRA to evaluate patients with erectile dysfunctions. There are no financial disclosures, but I have to admit, I did not anticipate how embarrassed I was going to be at the time I agreed to give this talk. Okay, so erectile dysfunction is experienced by a relatively large number of men spanning a wide range of ages, an estimated 20 to 30 million in the US, 20% of men between 30 and 79 years of age. It's commonly treated with phosphodiesterase 5 inhibitors or with intracavernosal injections. But when these pharmacologic treatments fail, then you can explore vasculogenic causes such as impaired arterial inflow or some kind of arterial venous communication that does not allow that allows for deflation of the cavernosa. So what she did was commonly starts off with a Doppler ultrasound, and here's an example of a patient who has a very prominent vessel. And then if something is seen or it's not diagnostic, then those patients would go on to a time-resolved contrast-enhanced MRA. And here you can see, for example, a very prominent early vascular communication at the base of the penis. So for this examination, the patient preparation is critical. You need to have an intracavernosal injection with an erectogenic agent, and then you perform the time-resolved MRA. And if there's inadequate tumescence, such as in this case, then the exam has to be repeated. So for example, this patient had inadequate tumescence, so it was repeated. And then on the repeat exam, you could see better detail of the vascular anatomy. So she had 26, I'm sorry, that's a typo, erectile dysfunction patients who had failed to improve with pharmacologic therapy. They all underwent routine Doppler ultrasound, and then they underwent the 3D twist time-resolved imaging, starting with the mask, then beginning the MRA simultaneously with a standard dose of gadobutrol at 2 ml per second, followed by saline flush, and then performing the 3D rendering with a standard workstation. The temporal update rate was 4.6 seconds with a voxel size of 1/2 by 1.25 millimeters. She had 29 MRA examinations in 26 patients. 2 of the exams failed due to the incomplete tumescence, and the patients were brought back and had a successful repeat exam. One patient was imaged both pre and post-surgical correction. All of these patients, venous pathology was identified. Early venous drainage in 22, vascular plexus without early venous drainage in 3, and a blush of contrast in the corporal tissues without early venous drainage in 1 patient. In addition, 3 of the patients had delayed cavernosal artery enhancement, indicating an arterial inflow problem. And of these 26 patients, during her 1 year of fellowship experience, 10 of them went on to surgical correction, and all were subjectively improved afterwards. So I'm just going to show you one. Oh, also, she, on the time-resolved images, she looked at the typical time to the abnormal venous enhancement, which had a mean of around 14 seconds, which shows you don't really need to run the tricks at too extended amount of time in order to capture these observations. So here's just an example case of a 46-year-old male with erectile dysfunction for 15 years. And on the time-resolved MRA, you could see this early communication from a vascular malformation. And this patient then went on to surgical correction and was normal postoperatively. Thank you very much.